Hi, welcome. Our presentation will be on COPD. I'm Tamara.
I'm Autumn.
I'm Shamara.
I'm Caroline.
And I hope you enjoy our presentation.
Thank you.
Hi, we have a patient. Her name is Caroline Augusti, 22 years old. Her symptoms are wheezing, coughing, sputum production, and dyspnea on exertion. Would you like to see her now?
Yeah, send her in, sure.
Okay.
Hi, Caroline. Good, thanks. How are you today, hon?
Good. So I've been having some shortness of breath recently.
Okay.
Difficulty to breathe. I've had this terrible cough for about 3 months. I get it around this time of the year for the last couple of years.
Okay.
I usually take Mucinex and it usually subsides enough to function.
Okay.
But now it's causing too much of a difficulty for daily activities.
Oh, okay.
I recorded myself. If you'd like to hear me.
Sure.
Yeah, there you go.
This is you?
It's quite nasty.
Wow, Caroline.
Are you having any chest tightness?
So yes, chest
Do you have
tightness.
productive sputum when this happens?
Yes, my spit, I cough up a lot of spit and usually a greenish tone.
Is it thick?
Very thick.
And do you have trouble breathing when this is happening?
Yes.
Does your chest feel tight?
Yes, when this happens.
Okay. Are you a smoker by any chance?
I am.
How long have you been smoking?
Since I was 12.
Oh my goodness. First thing I want to do, I want to get some lung sounds on you just to see what they sound like right now. When was that recorded?
About a week ago.
About a week ago.
And how the appointment?
Yeah. Okay. Well, I'm glad you came in. Okay. I'm just gonna put your hair back here. Sorry if my hands are a little cold. Can you take a deep breath in for me, hon? And out. In. Out. In. Out. In. Out. Okay, thank you. So I definitely hear wheezes all over your lung field. And I think that's definitely, you know, what's probably causing all of this. I think we should, what medication did you say you were on?
Just the Mucinex.
Just the Mucinex?
Try to get that all out.
Yeah, I think we gotta put you on like maybe a bronchodilator.
Okay.
Just to get everything kind of loose. And maybe get you some medication just to kind of dry you out as well.
Okay.
What do you think about that?
Yeah, anything to make me feel a little bit better.
Have anyone ever told you maybe you have chronic bronchitis?
I think my doctor said something about that at my last physical, but I didn't really do anything about it.
Didn't follow up with them?
No.
Okay, well I'm glad you came in today. So I'm gonna have you do and so we're gonna do a diagnostic test. We're gonna have you do use our census spirometer.
Okay.
And that's basically just gonna assess your lung and how much you can, how much air you can oh my god, I can't say it. Expel. Okay. Would you be comfortable doing that today?
Sure.
You feel up for it?
Yes.
Okay. And I see that you have some gauze on. You were recently in the hospital.
Yes.
Okay. Alrighty, hon. So we're gonna try our best to take care of you today. Okay.
Okay. Thank you, guys.
Okay. So we mentioned that we were gonna teach you how to use an census spirometer. So today I want to provide you with a video and watch the video along with you, so that way you know how to correctly use it when you get home. Is that okay?
Yes. Thank you.
Okay.
Your incentive spirometer is a tool that will help keep your lungs healthy after surgery. Surgery and anesthesia can lead to less activity in the lungs, which can put you at risk for pneumonia. The incentive spirometer helps to protect you by expanding and exercising your lung capacity. You will use this tool regularly while in the hospital after surgery, and we want you to practice using it at home in preparation for your visit. The incentive spirometer has a mouthpiece, a main chamber with a piston, and a goal marker to show your progress. It also has a flow indicator to help you inhale at the correct rate. To use the incentive spirometer, sit up as far as you can in bed, on the edge of your bed, or in a chair. Hold the incentive spirometer upright with the good, better, best label facing you. Exhale fully before you begin. Place the mouthpiece in your mouth and seal your lips tightly around it. Breathe in as slowly and deeply as possible. This will raise the piston in the main chamber. Try to keep the flow indicator in the better or best position throughout your entire breath. The marker tab shows you the target that your doctor wants you to raise the piston to each time you use your incentive spirometer. At the end of your inhalation, hold your breath for at least 5 seconds, allowing the piston to fall back to 0. Take your time and slow down if you begin to feel lightheaded. Now, see if you can do it yourself. Sit up straight on the bed or chair, exhale fully, seal your lips around the mouthpiece, and then breathe in as slowly and deeply as possible. Don't forget to hold your breath for at least 5 seconds to allow the piston to fall back to 0. You will repeat this 10 times at each practice session. Always remember to sit up straight, inhale slowly and deeply, keep the flow indicator in the better or best position, slow down if you feel lightheaded.
I'll use the incentive spirometer. Was there anything else you needed to be counseled on? Do you think you can follow the video?
Yeah, so I'm going to sit up straight in a chair at the end of a bed. I will exhale beforehand.
Okay.
Put my mouth on the piece. And while I inhale, I'll try to get the piece to my goal and stay in the best and better categories on the side. And then I'll hold my breath for 5 seconds to bring it back down. And then I should practice that multiple times a day, right?
Yeah, I want you to try to do at least 10 times within an hour.
Okay.
You're just sitting down, watching TV, just to kind of, get your lungs to be expanding again, okay? And I'm also going to prescribe you 2 medications. I'm going to send them over to your pharmacy. I'm going to prescribe you Dulera and albuterol, your ProAir, I should say. So the blue one, I want you to take every single day.
Okay.
You don't have asthma, but I'm going to treat you as if you have asthma, just to kind of get everything dilated. I'm going to put you on bronchodilators, okay? So again, this one you're going to take every single day. And then this guy here, I want you to keep with you at all times. So if you're having like any times where you're feeling like you're about to have like a really bad, you can't breathe, it's kind of like a rescue, okay? So you're going to take this one. So what's this one for?
That one is for daily, every day.
Okay.
And then the ProAir is for when I am struggling.
Okay.
For more of an immediate effect.
Okay, perfect. Alrighty, seems like you got it down packed. And we're going to have our secretary make you a follow-up appointment just so we can come back and see how you're doing, okay?
Perfect. Thank you so much, guys.
You're welcome. Thanks for coming in today.
Thank you.
Nursing Grand Rounds on COPD. Learning objectives. We will define COPD and the risk factors. We will identify the pathophysiology and the clinical manifestations. We will identify specific diagnostic tests for COPD. We will then choose the appropriate pharmacological agents to treat the exacerbations and maintenance of COPD. We will also use a nursing process to establish appropriate nursing care plans for patients with COPD. We will identify ethical dilemmas in patients with COPD, and then we will see what research indicates about the management of COPD. What is COPD? COPD is chronic obstructive pulmonary disease. It is a disease that primarily affects the respiratory system, causing airflow obstruction that is not fully reversible. It is known as the 4th leading cause of death and the 12th leading cause of disability among individuals today. COPD can be classified as chronic bronchitis, emphysema, or asthma. Chronic bronchitis is classified as having a productive cough with the formation of sputum for at least 3 months in 2 consecutive years. Emphysema is classified as impaired gas exchange as a result of alveolar wall destruction. With a patient with chronic bronchitis, there can be increased weight loss. The patient will have expiratory wheezing. They can have symptoms of peripheral edema related to right-sided heart failure. The patient can develop a smoker's hack. They will have coarse crackles or rhonchitis in their lungs. The patient often does not appear to be in respiratory depression or distress. Emphysema, on the other hand, the primary cause or primary clinical manifestation is wheezing. There is rare sputum production with an unproductive cough. The patient may use pursed lip breathing
to help increase their respiratory status. The patient may also position themselves in the tripod position and may often have a barrel chest. They may use the accessory muscles to breathe, leaning forward, again in the tripod position. Asthma is classified as chronic airway inflammation. Common symptoms of asthma include cough, chest tightness, wheezing, and dyspnea. Asthma is largely caused by an allergen, and it is largely reversible, with or without treatment. Now we will explore risk factors for COPD. Unfortunately, the primary cause of COPD is smoking. Moving on to passive smoking, increased age, occupational exposure such as dust or chemicals, indoor and outdoor air pollution, and genetic abnormalities can all lead to COPD.
Hi, my name is Shmara Jameson, and I'm responsible for covering the pathophysiology and the pharmacology portion of this assignment. I will begin with the pathophysiology. All cigarette smokers have some inflammation in their lungs, but those who develop COPD have an enhanced or abnormal response to inhaling toxic agents. This amplified response may result in mucus hypersecretion, which is chronic bronchitis, tissue destruction, emphysema, and disruption of normal and repair mechanisms, which is bronchiolitis. These pathological changes result in increased resistance to airflow, increased compliance of the lung, air trapping, and progressive airflow obstruction, all manifestations of COPD. Inflammation is present in the lungs, particularly the small airways of all people who smoke. This normal protective response to inhaled toxins is amplified in COPD. Besides inflammation, two other processes are involved in the pathogenesis of COPD. This is an imbalance of protease and anti-protease. COPD causes an increase in the number of neutrophils, macrophages, and T lymphocytes in the lungs. So, in general, the extent of the inflammation is related to the degree of the airflow obstruction. The main site of airflow obstruction occurs in small conducting airways that are less than 2 millimeters in diameter. This is because of inflammation and narrowing in the small airways. Other factors contributing to airflow obstruction include loss of elastic recoil and obstruction of the alveolar support. The airway obstruction progressively traps air during expiration, which results in hyperfiltration at rest and dynamic hyperinflation during exercise. Hyperinflation reduces the inspiratory capacity and therefore the functional residual capacity during exercise. These features results in breathlessness and limited exercise capacity, which are all typical of COPD. The airflow obstruction in COPD is best measured by spirometry, which is also key for its diagnosis. So just a rundown. Pollutants irritates the airway, resulting in inflammation and hypersecretion of mucus. Constant irritation causes the mucus secreting goblets to increase in number, thus leading to increased mucus production. Then, ciliary function is reduced. The bronchial wall thickens, the bronchial airways narrow, and mucus, it may plunge airways. Alveoli, they become damaged and fibrosed, which results in altered function of the alveolar macrophages. When these alveolar macrophages are damaged, they destroy foreign particles, including bacteria. So as a result of that damage, patients become susceptible to respiratory infections, especially during this time, the winter season. Some effects of COPD. Gas exchange abnormalities. These occur in advanced disease and are characterized by arterial hypoxemia with or without hypercapnia. There is also pulmonary hypertension. This develops late in COPD, at the time of severe gas exchange abnormalities. Contributing factors to this includes pulmonary arterial constriction. Systemic effects of COPD. Systemic inflammation and skeletal muscle wasting contribute to limiting the exercise capacity of patients and worsens the prognosis irrespective of the degree of airflow obstruction. Patients also have an increased risk of cardiovascular disease. So now I'll move on to the pharmacology portion. The current treatment for COPD is symptomatic and is mainly based on bronchodilators, which can be short-acting and long-acting, anticholinergic, corticosteroids, theophylline, or a combination of these. The objective of pharmacological treatment of COPD is to prevent and control symptoms, reduce the frequency and severity of exacerbations, and improve general health status and exercise tolerance. So bronchodilators are used to relieve bronchospasms by improving expiratory flow through widening of the airways and promoting lung emptying with each breath. So for the short-acting bronchodilators, they are used to manage acute symptoms. One that's mainly used is albuterol. So with this one, it is used for bronchodilation, which basically the bronchial smooth muscles, they bronchodilate. So basically the smooth muscles, they relax. However, there are side effects to this medication, which includes tachycardia, bronchospasm, hyperglycemia, tremors, hypertension, and chest pain. Then you have long-acting bronchodilators, which you would not give for an acute symptom. One that's mainly used for COPD is Spiriva, and it is a handheld inhaler that relaxes and opens the bronchi. Then we move on to anticholinergics. So the only anticholinergic that's used to treat COPD is ipratropium. It may be used in patients who do not tolerate short-acting beta-2. Side effects of this anticholinergic is dizziness, headache, blurred vision, dry mouth, hypertension, and sore throat. Then we move on to the corticosteroids. The corticosteroids are used to control inflammatory response that occurs in COPD. They do not relieve acute symptoms. Some side effects of corticosteroids are osteoporosis, weight gain, depression, muscle weakness, the Cushing syndrome, glaucoma, and cataracts. Also, patients must avoid NSAIDs, and it must be administered with foods. For the inhaled corticosteroids, one frequently used is Flovent, and for systemic corticosteroids, a commonly used one is prednisone. This completes my portion of this assignment. Thank you.
Diagnostic testing and laboratory data. As shown earlier in our scenario with our patient Caroline, we can use the incentive parameter to help evaluate the airflow obstruction by measuring the forced expiratory volume. We can also conduct an arterial blood gas, which establishes baseline for oxygenation and gas exchange. We can perform a chest X-ray, which is used to evaluate the lungs. We can also do genetic testing or genetic screening to detect alpha-1 antitrypsin.
Our first nursing diagnosis would be impaired gas exchange related to chronic obstructive lung disease, as evidenced by either O2 saturation 90% on room air or less, complaints of shortness of breath, coughing up thick secretions, and the patient will maintain gas exchange within baseline by discharge. The nurse will monitor the client's breathing and hypoxia, monitor respirations and assess breath sounds hourly or more often as needed, and monitor arterial blood gases or ABGs, monitor oxygen saturation, and monitor the client's level of consciousness. Our second nursing diagnosis would be ineffective airway clearance related to bronchoconstriction as evidenced by increased sputum production, ineffective cough, fatigue or decreased energy, and bronchopulmonary infection. The patient will demonstrate deep breathing and coughing techniques by the time of discharge. The nurse will teach and give encouragement use of diaphragmatic breathing and coughing techniques, assist in the provision of action nebulizer and metered dosed inhalers, perform postural drainage with percussion and vibration in the morning and evening according to what's required. The third nursing diagnosis would be ineffective breathing pattern related to wheezing and secretions. The patient will improve breathing pattern. The nurse will place patient in semi-Fuller's position to have maximum lung expansion. She will place a pillow when the client is sleeping to provide adequate lung expansion while sleeping. She will increase fluid intake as applicable to liquefy the secretions. For patient education, the first thing you need to understand are the warning signs of an attack. For example, wheezing more than your normal amount, coughing more than your normal amount, shortness of breath, mucus increase or change in color, and shallow breathing. Although you may think exercising is bad, people with COPD should exercise regularly but be cautious. The following exercise routine can help strengthen your respiratory muscles. Some easy but effective exercises are stretching, aerobic or cardio exercises. Some low-impact aerobic exercises include walking and jogging on the treadmill, biking, and swimming. Some high-impact aerobic exercises, which are more difficult but manageable, could be jumping rope and running. You want to avoid exercising in extremely hot or cold weather. Hot, humid, and cold temperatures can worsen your levels of shortness of breath, affect circulation, and can even lead to chest pain. If at any point during your exercise you begin to feel dizzy, short of breath, or weak, you should stop exercising and give your body a break. You should also try to avoid lifting or pushing excessively heavy weight. A nurse should also teach the importance of avoiding irritants such as cigarettes, smoking, industrial air pollutants, dust, powders, perfumes, and aerosol sprays. They should teach the importance of using a bronchodilator, nebulizer, and proper medication. Lastly, you should teach the importance of adaptive breathing techniques such as deep breathing exercises, coughing techniques, pursed lip breathing, and abdominal breathing.
Discharge planning. The key is to relieve symptoms that allow the patient to breathe and feel better. As a nurse, you will have to work with the patient to make sure they know what must be done after they leave the hospital. Make sure the patient has a full list of their medications, knows how to tell them apart, and knows when they need to be taken. It is very important to protect yourself from infection. COPD patients are more susceptible to infection. Get a flu shot, get information on the pneumonia vaccine, and wash your hands as often as you can. Discuss lifestyle changes with the patient. Stop smoking, avoid secondhand smoke, humidity, begin to exercise, and a healthy diet. Schedule follow-up appointments with your healthcare provider. Pulmonary rehabilitation may be needed. This helps to teach breathing techniques, gives information about COPD, counseling, and diet and exercise planning. Lifestyle. Exercise will help reduce symptoms, improve quality of life, increases physical and emotional participations, and decreases your hospitalization. Cessation of smoking, you're more likely to see pulmonary function improvement. It is very important to know when to seek help. In many cases, COPD is reoccurring and can worsen if these things are present. It's important to call your healthcare provider or 911. You should call your healthcare provider if you have chest pain while inhaling, a fever higher than 101.1 Fahrenheit, coughing mucus that is thick, blood-stained, yellow, green, or smelly, shortness of breath, swollen ankles, or tachycardic. You should call 911 if you have difficulty walking and talking because of shortness of breath, bluish or gray in the fingertips and lips, when your medication isn't making breathing easier, if you're fast breathing or difficulty catching your breath, chest discomfort including pressure, fullness, squeezing, or pain that lasts longer or causes discomfort to move to arms, neck, jaw, and ethical dilemma. Ethics with COPD usually tend to be associated with end-stage COPD cases. Patients are usually choosing from aggressive treatments or palliative care. Aggressive treatment would be to try to recover and heal. Palliative care would be to relieve symptoms to provide comfort for the remaining time. This is something that the patient is allowed to choose. Patients often make these decisions based on their religion and input from their family and doctors.
Care bundles in the management of a COPD exacerbation. The article by Lloyd and Garside compares what they illustrate as care bundles to manage COPD and lower hospital readmission rates. COPD exacerbations limits patients' quality of life and are among the top reasons for 30-day readmissions to the hospital. When a patient is readmitted with COPD exacerbations, unfortunately, hospitals do not receive payments for additional treatment of the patient. The article explores 6 different care bundles and examined how effective they were in preventing readmissions. 2 study groups focus on admission care bundles, while the other 4 focus on discharge bundles. The study concluded that care bundles can be effective, but it greatly depended on when the interventions were implemented. The study found that successful interventions that did not include pharmacological treatments were important factors to decrease the risk of exacerbations. Those interventions included pulmonary rehabilitation and patient education. Priority patient education focused on how to correctly use inhaler devices and medication. Smoking cessation programs were also a common strategy throughout the groups. Other interventions that the groups discussed that could be implemented either at admissions or at discharge included booking follow-up appointments and 48-hour follow-up phone calls. The article states that the entire care team and their understanding of care bundles will result in success rates of improvement of patient care.